Hello, everyone, and welcome to today's AML Caregiver Chapter event brought to you by the HealthTree Community for AML program. My name is Katie Braswell, and I'm the HealthTree for AML Community Director. I'm very grateful to have each of you here for our meeting today and for your support in building this AML caregiver community. I'd like to let you know that today's session will be recorded, and the recording, along with the slides and any resources we discussed today, will be sent via email to all registrants within 48 hours after the event has concluded. I'd like to start with a brief Zoom meeting tutorial for those of you who are new to using the platform. We'd love for you all to turn your camera on and keep your cameras on if you feel comfortable. Doing so helps us to create a stronger sense of community. You can see on the slide how to turn on your camera. At the bottom of your screen, you should see the microphone and camera buttons. You can click the video icon that says Start Video in order to turn your camera on. With that being said, if you're not comfortable being recorded, you're not required to keep your camera on. Your microphone should currently be off and will be kept off by our team throughout the presentation. During the group discussion at the end, you're welcome to unmute yourself once you're called upon. If you have any questions or comments for us or for our speaker throughout her presentation, please click the chat icon and then type them in the chat box. If you're using a mobile device or a tablet, click the three-dot icon that says More and then Chat in order to access the chat box. And lastly, if you would prefer to verbally ask a question or make a comment directly to our speaker during the discussion time at the end, we encourage you to do so. If you are using a laptop or desktop computer, click Reactions near the bottom of your screen and then click Raise Hand. If you're using a mobile device or tablet, you can click the three horizontal dots that say More and then click the Raise Hand button. And now let's get started with today's event. First, I'd like to thank our sponsors without whom this event would not be possible: Bristol Myers Squibb, Amgen, Genentech, AbbVie, and Jazz Pharmaceuticals. The topic of our event today is titled The Caregiver's Role in AML Symptom Management. Here's the agenda for today. I will introduce our speaker, Dr. Sara Tinsley-Vance, and she will spend the next 40 minutes or so giving us her presentation. After the presentation, we'll open it up for your questions and comments and end the event with a few announcements. So let me take a second to introduce our speaker. Dr. Sara Tinsley-Vance is a nurse practitioner and quality of life researcher who specializes in providing care to patients diagnosed with hematologic malignancies at Moffitt Cancer Center. She has been practicing as a hematology nurse practitioner at Moffitt for 30 years, 11 years in bone marrow transplant, 2 years in patient triage, and the past 17 years in malignant hematology. She is a member of the leukemia research team and cares for patients with AML, myelodysplastic syndromes, aplastic anemia, and other bone marrow failure syndromes. We are so pleased to have you here with us today, Dr. Tinsley-Vance. I know your presentation today is going to provide so much valuable information to everyone here in attendance. And so with that, I'll let you go ahead and get started.
Thank you so much. Let me share my screen. Hi, everybody. Thank you for those I can see. It's nice to be able to see us, even though we're in our little squares. At least I can see you. And for those I can't see, that's all right too. So let me share. Can you see my screen?
Yes, looks great.
Okay. Thank you. So we're talking about the caregivers today and how my goal is to really help you support your loved one or whoever you're helping provide care for. So let's get started. Approximately, let's see, I hit the go button and it didn't go. Approximately 3 million Americans are caring for someone with cancer. So that's a lot of people. So you're not alone. And our cancer caregivers tend to be women, about 58% of them, and most have less than a college degree, about 60%. So I know that doesn't apply to everybody, but these are just lumping them all together. And most provide care to a relative, 88% of them, which I'm sure you don't find that surprising. And it's like a full-time job if you look at these numbers here. An average of 32.9 hours a week caring for their loved one. 32% provide 41 or more hours of care. So that's more than a full-time job. And we know that we ask you to do complex medical things like nursing tests without many women and men being formally trained and the tasks that we ask you to complete, and the problem solving skills that like someone like I have learned over many, many years through trial and error, which is not the optimal way to learn. So what are these unique challenges specifically with AML? The symptoms are vague. They can go with a lot of different problems. And so teasing out which ones are related to the AML and which ones are related to something else are really like impossible to tease apart without really knowing the patient, knowing the disease. And if this is the first time you've had an encounter with AML, it's really like a very, it's a lot of stress on you. It's relatively rare cancer, about 20,000 new cases are projected in this year. And that's only 1% of all new cancer cases. And our AML patients and loved ones have like different problems than solid tumor patients because they usually have radiation and surgery, whereas most AML patients, our surgeries are putting in a port or a PICC line or a triple lumen Hickman and doing bone marrow biopsies. So just from the get-go, it's different. And we also have different types of chemotherapy. We have some similarities with solid tumors and some that are very unique to AML. We have complex terms, many of them. I did a presentation last night for an educational company, and even another medical provider who is co-presenting with me struggled with the names of the chemotherapy regimens. So it's difficult, and we recognize that the complex terms for the treatments, you have generic, you have brand name. So those are, just all the names together. And then the scheduling can be quite a hassle for many of our patients, trying to find a slot that fits for you. If you live far from the treatment area, for the area where you're getting treatment, that adds a layer of complexity. And then you factor in someone who's not feeling well, really a lot on your plate. And many times the prognosis is uncertain, from saying, yes, we do have a chance of curing you, to, well, we're not sure, we'll just see as we go, which is not really that reassuring. So this leads to stress. You're just stressed out. Good grief. So my objectives today is really to go over the most common symptoms that have been identified for AML patients and really try to help tease out, like, what can you do? How can you support that loved one? And then look at the blood counts and how those factor into those symptoms, and help you come up with a process for when you evaluate symptoms. And this is something that I learned in school, and I've kind of mastered over time and repetition, like this is how you approach a problem. First, I think organization. This is just my approach, a logical approach to looking at symptoms. You want to have either an app that tracks symptoms, and if you look, there are many free apps. But if you're sharing caregiving with another individual, it might be easier if you have one place where you keep all of the information, to where, you just pass it from one to the other and you keep it all in one place. Whereas with an app, you might not be able to do that. Although some of those apps, you can share your data. There's also digital folders, and you can use your camera to take pictures of labs or the medication list, things like that. And of course, we do have those patient portals. I have friends with cancer, and some of them use their portal well, and some of them never look at the portal. So find that system that works for you and try to stick with it, consistently going back to your system. The things that are essential to track, which many of you are aware of this already, is that accurate medication list. And I would include on that list over-the-counter medications or supplements that are being taken. You want an accurate medication, allergy list along with that medication list. And if possible, the type of reaction when that medication was taken. And for symptoms, you could have like a sheet directly just related to symptoms. One of the first things we ask is, when did that symptom start? And then one of the things that's on one of the tools I'm using with my quality of life research is whether or not they have a symptom, and then how distressing it is. So if you can think about the symptoms that your loved one is experiencing, or your friend, and then which ones are the most distressing to them. And then you can bring those up in your appointments when you go. And then add to that symptom list as the new symptoms develop, and the date of when it started. Another thing that really helps with making you feel prepared is having your emergency plan in place. It's hurricane season here in Florida, and we always are told to have a plan. And I think that's a good idea when you have a person that you're providing care to with AML, is know what the emergency phone numbers are for after hour, not just 911, but where are you going to go if there's a fever in the middle of the night? Who are you going to call? Where are those phone numbers? So if you keep that in your binder, or wherever you're keeping all of that information, to keep it together and try to stick with that symptom, or that way of evaluating symptoms and your medications and allergy lists. So the type of questions that I ask patients when they come in about their symptoms is, the first thing is, when did it start? Is this something that's all during, it's constant and never lets up, or is it intermittent? It comes and goes. And then you look at, if it's intermittent, what the surrounding circumstances are. And for sure, if it's a constant symptom, when did that start, and like what was happening at that time? So it's like you're a little detective trying to figure this out and put the information in place to point to the cause, the underlying cause. How long has this lasted? Is it like a past problem? If so, what was done when that past problem was taken care of? You want to know how severe it is, how distressing. We talked about that on the previous slide. And then, have they tried anything to alleviate the symptoms, and what worked? Anything make it worse? And how are those symptoms associated with something else? And if another symptom started at around the same time, it may be that those are related. And what do you think the problem is, and what are you worried most about? So having those like questions in your mind when you approach a problem, that if you present those when you go to the healthcare provider, it can really help them, in figuring out where the symptom came from and what we can do to help you. These are the most common symptoms in AML patients. I'm sure you're familiar and have seen these. Fatigue, that's the number one symptom, and that is not different from other solid tumors. Fatigue is one of our worst problems, and if we could improve fatigue, we could improve quality of life. A lot of the quality of life measures focus on fatigue and how much it interferes with the activities of daily living. Nausea is a common symptom, hopelessness, helplessness, shortness of breath, fever, pain, and that's especially in the bones. Leg pain can be particularly a problem, or the hip bone, sometimes the sternum. Fevers, and it's important to know what the blood counts are with that fever. A neutropenic fever can be life-threatening, so it's important to know what those neutrophils are. If you're the person that you're supporting experiences a fever, depression and anxiety, bleeding easily or bruising easily, and difficulty sleeping and drowsiness. So let's start with the number one problem that we see, and that is fatigue. It decreases quality of life. It's distressing. There are levels of fatigue, and we have instruments that measure that to see how dynamic it is throughout the day. So I normally ask them, what is your fatigue at its worst? And it's from 0, no fatigue, to 10, the worst. You may have seen this with your pain scale ratings. And then at what time of the day is the fatigue the worst? And what time is it the best? And then you can figure out how to schedule those activities that are the most important to your loved one during those times when the fatigue is the least. And we know that cancer-related fatigue is not relieved by rest. They can just wake up and still be so tired that they really don't feel like doing anything. Like even like taking a shower is a huge task. It's like asking someone to swim across the ocean, and they just have no reserve. And then we do know that when the anemia is worse, when that hemoglobin is on the lower scale, that contributes to fatigue. So looking at that hemoglobin, and even after patients are in remission, we find that they still don't feel that same level of energy. They still have fatigue. So it's very challenging to treat. And I'm sure that you have seen this fatigue. I'd like to refer you to the National Comprehensive Cancer Network, NCCN, has a patient and a caregiver area, and there's a complete section focused on cancer-related fatigue and strategies for figuring out what's contributing to the fatigue. And then they have a list of things that you can do to try to improve the fatigue as much as possible. Much of this fatigue is related to the cancer itself, or the treatment, or the changes in the blood count. So they're all interrelated, and it's hard to tease those all apart. But you have to start somewhere. So if you look, anxiety and depression contributes to fatigue. Being dehydrated can contribute to fatigue. Not resting well. So looking at all those variables and see which ones you can do something about to try to improve the fatigue. So it's nccn.org, and then they ask you if you're a healthcare provider or not a healthcare provider, and then they have a supportive care area, and that's where you'll find fatigue. It is beneficial to track it over time to see how it changes. And we also have learned from studying patients and caregivers, not in AML, but in other disease states, that many times the patient's level of fatigue is similar to the caregiver's level of fatigue. So just to acknowledge that this can be difficult, being a caregiver, and that you get fatigued as well. And so some of the strategies you're using to help your loved one with fatigue, you can do it for yourself as well. I think back of going on a plane where they say, put the mask on you and then put it on your child or your kid or your loved one. So take care of yourself, and then you'll be better able to take care of your loved one or the person that you're providing, being the caregiver for. This is showing you some cancer-related fatigue, like how to diagnose it, and then some strategies for helping manage fatigue. And you'll see on the left, there's the clinical history, so type of disease, AML. For stage, we really don't have specific stages for AML. We have different groups where we say you have favorable risk, intermediate risk, or adverse risk AML. And each of those risk categories tells you whether that individual with AML has a likelihood of being cured with just traditional chemotherapy. But to my knowledge, we've never separated out levels of fatigue based on those three groupings. So just having AML, we know that fatigue is part of it. And then the fatigue assessment, when did it start? How long has it lasted? And then we talked about alleviating and worsening elements of the fatigue. When does it worse? When is it better? And then how much does it interfere with those normal activities that the person loves to do? And then on that third box to the right in the green, you'll see other symptoms. We talked a little bit about this. Does the fatigue come along with nausea or pain? Is it associated with emotional distress like anxiety and depression? Are there other cognitive symptoms? Is there some confusion or agitation that occurs? Is there problems with sleeping? Not able to sleep because they're worried or having pain? And then is there a nutritional imbalance? And what do those labs look like? Which is really important when you have AML. Looking at that complete blood cell count with the differential and see what's going on there. And then that fourth box to the right is looking at other illnesses. Does the person you support have heart failure or chronic obstructive pulmonary disease? Do they have asthma, bronchitis? Or are there problems with their thyroid? And seeing if any of those may be contributing to the fatigue. And then you see in the like maroon box, the step 3 is management. So patient and family education, I think of that as caregivers, physical activity, psychosocial intervention, and then pharmacologic intervention. So as was mentioned on that previous look at how we manage fatigue, it is a mind and body experience. And so if we're going to treat fatigue effectively, we have to aim the things that we do to take care of both the mind and the body. And getting back to those labs, what does that hemoglobin look like? If the hemoglobin is less than 7 grams per deciliter, then a transfusion is needed, and that could help some with the fatigue. I recognize that it doesn't alleviate all of the fatigue, but it can help. If your loved one has some problems with their heart, or they have chronic obstructive pulmonary disease, then sometimes we give a transfusion with blood when the hemoglobin is hovering close to 8 grams per deciliter. When in doubt, ask your healthcare team if they think that a transfusion with packed red blood cells would help with fatigue and other symptoms. I've also found that for some of the patients I provide care to, when their hemoglobin gets lower, they have more difficulty sleeping at night. Like they become restless, they wake up easier when that hemoglobin is lower. So again, like piecing together the symptoms that may be related. So that takes like experience, but just paying attention to it, I think you'll be able to put those pieces of the puzzle together. And so exercise, that just sounds like it doesn't go with fatigue, but many studies have shown that exercise does help reduce fatigue. And why is that? Well, one of the theories is, or things that they've shown when they check for these markers of inflammation in the body, is that it reduces inflammation and that reduces fatigue. But we don't have a prescription, like so many hours or so many minutes of exercise per day for this person, for this condition is the right amount. So there's some trial and error there. And as you can imagine, it's difficult to get motivated to be more physically active when you don't feel like doing anything. So this is some of the obstacles that we meet when trying to overcome fatigue. Some of the things that we know can help make it better are just not things that you can get that is easy to do, right? And again, it's important to know what the hemoglobin and the platelet count is. Studies limit participation when the platelet count is less than 10,000. They have there are several studies looking at using both aerobic and some weight training exercise to inpatient AML patients. But many times they only have like 30% completion rate. And that's because when the platelet count was less than 10,000 or the hemoglobin was less than 7, then they didn't recommend that the person exercised on that day. So you can see how this is difficult with an AML patient. So I would just encourage to do some form of physical activity, you know, if your loved one is well enough. And if it's safe, that's another really important thing. And for you as a caregiver, if you can structure your day in a way to where you can have either some walking, some yoga, some of those other forms of exercise that really like focus your mind and your body, can help improve fatigue and encourage you to take the time to stay healthy and take care of yourself. So these are some of the medications that have been used for cancer related to fatigue. Stimulant class of drugs, there's limited data. 3 studies showed methylphenidate in comparison to placebo, and 1 study with dexmethylphenidate. So and there were like 16 studies that they looked at. So in that, only 4 studies showed the benefit of stimulants. There are also antidepressants, paroxetine. There were mixed results from 2 of those studies, one showing improved fatigue and the other without a difference. And they were comparing paroxetine to placebo. Dexamethasone and methylprednisolone are both steroids. And these were studies done in patients who have solid tumors that had metastatic disease, meaning that it moved from its original site to another distant site. So for those patients, it did improve their fatigue. It really hasn't been studied in AML. We do use steroids with our anti-nausea regimens, but it hasn't been specifically used looking at a way to improve fatigue. And that's because it can mask infection too, which is a major problem. And you wouldn't really want someone who's a diabetic to be on a lot of steroids because it increases the sugar or the glucose. And it's really not appropriate for long-term use. So you may get some limited improvement in fatigue. And then when you withdraw it, sometimes the fatigue is worse. So what about supplements? There's a lot of interest in supplements for cancer-related fatigue. And there's no consensus in this looking at a systematic review where they go over all of the data that's available from studies to see, you know, what's the best approach with supplements. There was no consistent consensus for supplement recommendations. And that's a challenge with AML because we know that supplements can affect the blood count. The majority of supplements have not been, or they're not FDA approved, so they don't go through that process where you see what the toxicities are, can they lower the blood counts, and do they interfere with the chemotherapy itself. There's a really good website where we check things when a patient comes in on supplements to see if there's interference with other medications. I would say that database is not very complete. And so my recommendation would be to really just make sure that your healthcare team knows the supplements that the loved one you're supporting is taking. And if you really want to try something, that you have that discussion with them before just starting them on it. The other thing that I touched on was treating the mind. You really want that education focuses on the recognition that emotional distress is closely linked to cancer-related fatigue. And with the education, they teach coping strategies for anxiety, depression, and distress, and looking at those patterns of fatigue and finding a balance between fatigue and activity. We talked about that prescription of exercise that can help fatigue and not make it worse, and then increasing awareness of fatigue patterns. And journaling is an important aspect to this, of educating ourselves about, what works and what's really going on with the patient. And then rating fatigue, promoting activities, like which activities make fatigue worse and which make them better. And then restructuring the day, we touched on this some. And there's also been cognitive behavioral therapy that's been studied as a way of managing cancer-related fatigue, looking at the emotions, behaviors, and that whole cognitive process. And this is a treatment that usually begins after the treatment for the AML has been completed. And this is coping with that experience of the cancer. Like, people develop post-traumatic stress disorder, which can be part of that fatigue process, having dysfunctional thoughts and fear, anxiety, which contributes to dysregulation of sleep and activity. And several studies have shown that this cognitive behavioral therapy can reduce fatigue. So treating the mind and the body. This would be the mindfulness-based stress reduction. One of my mentors has several studies with this in the breast cancer population. So there are these different types of meditation therapy, is what we mean when we talk about mindfulness-based stress reduction. And the core practices are the sitting meditation, and then being aware of your breath, and then focusing your attention. And you become aware of those sensations in the body scan. Yoga exercises can be a part of this, or walking meditation, and then insight meditation. So these are some of the elements that are included in mindfulness-based stress reductions. And it really has shown that these practices can improve cancer-related fatigue. And there are many free online resources available, particularly on YouTube. But for them to be effective, it has to be something that's incorporated into a regular pattern, so that you get the mind and the body engaged on a regular basis, to try to decrease that fatigue level. So nausea and vomiting, let's talk a little bit about that. That can be a real problem. Chemotherapy-induced nausea and vomiting occurs in about 80% of patients. It's distressing and decreases quality of life. And they group the chance of developing nausea and vomiting into different areas, whether it's really highly likely to cause nausea and vomiting, or it's intermediate, or it's low risk of causing it. And inpatient intensive chemotherapy, it's about a 30 to 90% chance of causing vomiting, and our outpatient-based types of therapy varies, but can be as high as 80%. So that's quite a range, from 30 to 90%. So just being aware of that. And then we know that medications can help, but also knowing what the triggers are for nausea and vomiting, that can help you avoid those triggers, and look at the medication list to see how we can adjust it, and time our anti-nausea medications at the right time. Foods or smells of foods can really set people off. So one of the strategies I learned early as a nurse was that if smells are really what's setting off your loved one, you want to, how the dinner plates for hospital foods come with them covered, is that they're supposed to uncover them before they go in the room, so that the smell doesn't make the person nauseated. So just to be aware of things like that. And then you may want to group those medications all together that you have that are available for preventing or treating nausea and vomiting so that you can get to them quickly. And you want to keep track of the time when it was last taken, and also monitor how many episodes of vomiting and, like how much fluids are your loved one able to continue to take in. Even if you just have a general idea, that can help when you talk to a healthcare provider and helping them determine whether they're likely to be severely dehydrated. Of course, we have a cheat factor. We look at the chemistry profile and we can tell pretty quickly whether they're dehydrated from nausea and vomiting. But you can kind of figure it out too if you're watching their fluid intake and then watching how many times they vomit. So being prepared for traveling. This is something I wish I would have learned a long time ago from traveling with kids, is being prepared. Nausea medication prior to travel if they're prone to motion, making the nausea worse. Packing a bag to be prepared, the wipes, a disposable bag, a change of clothes, some ginger chews, something to rinse the mouth off, right? And then I have on here reducing odors, perfumes, air fresheners, musty smells, foods. Reducing those odors can help with feeling nauseated. And then light snacks for when that nausea passes, or sometimes that can help even if it's related to having a low glucose level, like saltines and ginger snaps, or things that you may be familiar with. And then there's alternative medications for nausea and vomiting. Acupressure. There are some pictures in there, like where you hold to help reduce nausea and vomiting. And you may have seen those bands that I've seen on planes sometimes for people that are prone to nausea and vomiting when they travel on an airplane. Aromatherapy, specifically peppermint oil, and you can see some of the references down below. Ginger used with caution when platelets are low, and then guided imagery or hypnosis. Those have been found to help with nausea and vomiting. And for fever, if those neutrophils are less than 500, that's called severe neutropenia and can be life-threatening if your loved one has a fever and they are neutropenic. That's called febrile neutropenia. And that's a one-time temperature of greater than 38.3 degrees centigrade or 100.9 degrees Fahrenheit, or if that temperature is greater than 100.4 and it lasts for 1 hour or more in a patient who has a neutrophil count less than 500, and or if an absolute neutrophil count is expected to decrease to less than 500 within a 48-hour period. So keeping a copy or knowing what the most recent neutrophil count was and when the last chemotherapy was given, those can really help the healthcare team figure out if they're likely, if your loved one's likely to have febrile neutropenia. Let me take a peek at the time. Okay, I think we're doing all right. What is the risk when a person has a neutropenic fever? They can have an overwhelming, life-threatening infection. So this one is really an important one. We tell our patients to seek immediate medical attention if they have a fever, and their neutrophils are less than 500. Sometimes there's other symptoms, and sometimes it's just a fever. If your loved one seems confused at any time, I would contact that healthcare team unless they have a history of dementia, and that's like their norm. That can be the first sign that they're getting ready to have a fever, or some of our older patients don't get a fever, they just get confusion. So always contact your healthcare team if there's a big change in your loved one, specifically confusion. And so these other ones we've touched on. So if your loved one has a fever and they're not neutropenic, I think that's just where the other symptoms really help to figure out where it could be coming from. Do they have a cough? Do they have new or worsening shortness of breath and their hemoglobin is stable? Shaking chills, even without a fever, is a worrisome symptom. But with a fever, many times I've seen that's the sign that the bacteria is going through their body when they have those really intense shaking chills and then get a fever. New IV used for treatment, like a port or a newly placed PIC or a Hickman, and then your loved one gets a fever. So those might be the sites of the infection, knowing that those were just recently placed. Difficulty with urination or not very much urine output can signal that they have a urinary tract infection, change in appetite or confusion like we talked about. And you want to know the medications. And if you have a way of monitoring vital signs, those are really important things to be able to report to the healthcare team, especially if it's a call in the middle of the night. Those pulse oximeters you can get at CVS or Walgreens, so where you can see the pulse and you can see the oxygen saturation, or if you can, and those would be important. I think they're about $25. We bought one during COVID. My husband had COVID, and so we could see if his oxygen saturation was stable or if that was changing at all. And it can be reassuring, actually. And then if you have a way of monitoring that blood pressure, that's an important piece of information. And hopelessness and helplessness, this came out over and over again in the research that I've been reading. It's closely linked with anxiety and depression, and it's totally understandable with this serious illness. Like, is this time to start like turning off the lights, like this picture, this photograph implies, and it's associated with a pessimistic cognitive style. Like if your loved one is someone that always has a cup half empty, this might be something they struggle with. And really your role as a caregiver is to listen, support, and encourage them. Very grateful for your support. That's really your presence sometimes is all that's needed to really help a patient get through this. We also recommend involvement of our social workers, chaplains, or other people that have really helped your loved one during periods of rough times, that you may want to ask them for some help. And you may need a break from caregiving sometimes for someone who's got this hopelessness and helplessness. And we can get into this hopelessness, helplessness, like pulling all of us down, if we let ourselves go there. So we need help. And when you need help, make sure you reach out to others for that. And then shortness of breath. What's the hemoglobin? We keep going back to this. What do the blood counts look like? If the hemoglobin again is less than 7, a transfusion is indicated. If the hemoglobin is stable, then there are likely other causes at play. Many times with AML, we see pneumonias, sometimes fungal pneumonias that take up residence in the lungs when those neutrophils are low. And the way that you can determine that is from looking at a chest x-ray or a CT scan of the thorax. And so I think that your role as a caregiver is really just to assist with the recognition of symptoms and when they started. Also, if you are aware of when that last imaging of your loved one's lungs have been performed, that can be an important piece of information for the healthcare team to know if you're going from one facility to another where they might not have immediate access to those radiologic findings. And is there any swelling that swelling may or may not be related to shortness of breath, but swelling in one extremity could indicate that there's a clot, or if it's swelling on both sides or generalized swelling, it could relate to heart function. And so those are things that we look for when a patient comes in as far as evaluating that shortness of breath. And there are new classes of drugs for IDH1 and IDH2 inhibitors that are for mutations that the drug are inhibitors, the ivosidenib and enasidenib. If there's rapid onset of shortness of breath, then that can indicate that there's something called differentiation syndrome. And then you definitely want to reach out to your healthcare team to report new symptoms. And then pain, bone pain we talked about from the leukemia. Other pain symptoms are also experienced. Important to know when it started, what makes it better, what makes it worse, how severe is the pain, does it move, characteristics, does it shoot, is it shooting, is it burning, stabbing, tingling, constant or intermittent, and other symptoms that occurred at that time. For really severe headaches, if the platelets have been low, I would make sure that you report that. Sometimes we do get some bleeding in the brain tissue, and you would want to know right away because you would want to get platelets transfused at a higher threshold. Like instead of 10,000 or less, sometimes we make it 50 or 100,000. And we typically would admit a person and monitor them closely to see what happens with that bleeding over time. And then for your role in pain management is really helping with that communication with the healthcare team and regarding how the pain impacts your loved one. We generally avoid Tylenol or those non-steroidal anti-inflammatories until you really discuss those with the healthcare team. Why? Because it can mask fever. For your non-steroidal anti-inflammatories, those can also cause some problems with the kidneys, and it can increase the risk of bleeding when those platelets are low. So again, getting back to that accurate medication list, I'm going to hurry up a little bit because we're running out of time. Depression and anxiety. A lot of this is related to the uncertainty, and it can decrease over time. And then social workers, psychologists, palliative care specialists, and chaplains can be helpful. The bruising and bleeding is directly related many times to the platelet count and can be worsened by blood thinning agents and also our non-steroidal anti-inflammatories. When the platelets are less than 10,000, a transfusion is needed. If your loved one is bleeding and the platelets are less than 50,000, we normally would transfuse platelets at that time, and then monitoring for bleeding and letting your healthcare team know if you see bleeding. And again, at the bottom of this, if your loved one falls when they have low platelets, you really want them evaluated because they could bleed internally from just having low platelets and having some kind of trauma. Difficulty sleeping is pretty common, contributes to fatigue. Other things that can cause problems with sleeping are pain, anxiety, the treatment itself. If they get steroids during the treatment, that can do it, or progressive anemia. The hemoglobin is low. That also contributes to difficulty sleeping. And then the treatments are directed at the underlying cause, again, looking at when it began. And there are medications available, yoga, exercise, cognitive behavioral therapy, as we discussed previously. Drowsiness is a common problem that's distressing to AML patients. And some of this could be related to the fatigue and then getting the nights and days mixed up, right? And then sleeping during the day and being awake all night. So trying to get into our regular nighttime sleeping, daytime awake time helps. Distress, depression, and anxiety. And so if you could just work on keeping the patient safe during this time with the drowsiness, right? We get stumbly. So in summary, you are the eyes and ears of the healthcare team. And more than just being the eyes and ears, you're just an invaluable member of this team, and you're a part of the journey. And we really rely on you to be a part of this journey. And I can tell you during COVID, when caregivers were not allowed in, the patients were so vulnerable. So I really, I learned from having them taken away how much they're valuable part of the whole treatment, the team that takes care of the patient. We do some of the support, but really the strong lifting is you all. And I'm really thankful for everything that you do. And remember to take care of yourself. And so thank you. Thank you for letting me spend this time with you. I think we may have time for some questions.
Thank you so much, Dr. Tinsley-Vance. That was excellent. You provided so many practical things for us to think about and things we can use in our day-to-day as caregivers. So that was excellent. And the slides are so valuable. We'll be sending them out to everybody to reference as you care for your loved one and as they go through different stages of their journey. So thank you so much.
You're welcome.
We do have a little bit of time for Q&A. And so let me share my screen again to remind you, we can take questions via chat or by having you raise your hand if you'd like to verbally ask anything. I have a few pre-submitted questions from people who couldn't be here today, but I'd love to get to the questions of those of you who are here. So if you have anything, feel free to jump in. I'll give it a few seconds, and if not, I'll kind of go ahead with the pre-submitted questions I have. So maybe while I see people chat or have a little bit of time to chat, I'll ask a question that was submitted by a few people. So they were asking about the management of poor appetite, which I know is probably contributed to a lot of things that you mentioned in your lecture, nausea, fatigue, pain, things like that can hold us back from eating, certainly. But I'm wondering if there's any specific tips you may have for poor appetite specifically, and maybe if there's any medications that should be brought up as appetite stimulants in AML, or is that something that's used or beneficial?
There's trying to think of the name of that article, but there's a lot of conflict that comes from the fights over food, like trying to get a loved one to eat. And the more you push it, a lot of times the more they resist. And I think there are medications that are used that we don't really, we don't use them that much. I know weight loss is a huge piece of AML, more so for men than for women. We use supplements, not supplements like the pills that you take, but like your Boost and things like that, and mix them with ice cream. Trying to think, there's a hormonal pill that we have used before, not a pill, it's a suspension, but the data is really mixed on that. Trying to think of other things I've done in the past. This really falls into the palliative care, not meaning hospice care, but supportive care. And there's lots of good resources on that. My mind is drawing a blank of the name of the medication that I have prescribed before, but there is a pill form of Marinol that it has been used for appetite stimulation. It's not pot, but it is the active ingredient. So we have used that before with some patients, the Marinol with mixed results. And there is it's a hormone, and I'm blanking on the name, that has been used, and I'm probably blanking because I don't like to prescribe it. It's associated with blood clots, and I've had some bad luck with that, and it ended up causing me seeing clots in patients after I prescribed it. So I would just encourage them to, and sometimes they use steroids, but again, there's a risk benefit of steroids in the active treatment setting, because of the risk of masking an infection and making the masking a fever, and just decreasing recovery of I don't know, in a non-natural way, I think is what I'm trying to say, and causing more harm than good. So I would get a dietitian involved.
Yeah.
We use those quite a bit.
Yeah. Helpful. That's helpful. I think, getting to kind of what the underlying cause is, and a lot of the things you mentioned in your presentation today are those underlying causes that hold people back from eating during treatment. So
and I know many times I suggest that they use things that have a lot of calories, like peanut butter with crackers, or butter on everything, or and protein if they can get it in.
Sure. Yeah, nutrient density for sure. We did a presentation, maybe I'll kind of guide people to, we had some dietitians on at a previous event about maintaining appetite. And so maybe I'll refer that to you as well.
Yeah, I saw that. I should have watched it.
Oh no.
I saw it on your website.
Yes, on our website and our YouTube channel. I'll send it out as a link in the resources. I do have a chat here from Pat. She says her husband is in the hospital for 30 days after doing his induction. He's on day 13 and is due home in 2+ weeks. He's doing extremely well now. I don't really feel qualified to handle some of the issues you mentioned. I guess I will have to call 911, hopefully never. When he comes home at 4+ weeks, will he still be vulnerable to these things when he's home?
One of the things that happens is we monitor that neutrophil count, and one of the conditions for being discharged is that the neutrophils have to be at like 500. So not as vulnerable, but still not like normal. So it shouldn't be like a neutropenic fever in the middle of the night. Having said that, many times after the induction chemotherapy, where patients are in the hospital for 4 to 8 weeks, they get more chemo later. So there may come that time when those neutrophils go down again. But really having a plan and learning about the neutrophil counts and where to go if there's a fever in the middle of the night. I think that's the scariest part for people, because you think nobody's there, and I've been told this is an emergency. What do I do? So talking through those scenarios before it happens should help a lot.
Is there an alternative for people to calling 911? Is there usually a 24/7 line that's given to discharge patients? What other things can be done in like these emergency settings versus relying on calling 911?
I've been spoiled because I've been at Moffitt, and we have an urgent care area, and so if the patient lives close, like within 30 minutes, many times we have someone on call 24/7. So it may be, Pat, that they have something like that where you live, where you wouldn't have to call 911 in the middle of the night. You would call whoever's on call, and then they can direct you. Sometimes before we had our urgent care, we had we would directly admit people, and we have a neutropenic fever protocol. That's something I didn't say though, is if you go to an emergency room and you know that that they're neutropenic and that they had chemo, you want to make sure that the person that checks you in, which is probably not a healthcare provider, knows that this is a crisis. You've been told that this is an emergency situation, and it's critical that they get triaged quickly, vital signs, and that those neutrophils are low, because sometimes by the time the labs results, you've missed time to get those antibiotics going. Some places do have someone on call 24/7 or urgent care areas. That's a good point.
Great. And we'll end on this for the sake of time, but Pat's also asking your recommendations on the best thermometer for her to buy.
I think the best one to buy is the one that works, that you know how to work the best. And we don't recommend rectal thermometers, just to say that, because of the infection and, where it gets put. But sometimes the ones that you can put on the forehead don't work that well. And I use the old-fashioned, not the ones with mercury, but a good old-fashioned thermometer, and have been, taking the vital signs a couple times a day, or the temperature at least, to where you feel very comfortable taking the temperature. So I don't have a specific brand recommendation, but one that you're comfortable using and that you know where it's located. Put all of the things that you think you're going to need in one place in your house, like where you're keeping the information, the medications, the vital sign monitoring, if you have that capability, for sure, a thermometer.
Organization during a crazy time like this can seem tough, but it can have a lot of benefit to it, to be able to get answers quickly. So yeah, that's a really important point. Okay, so we'll wrap up. That was excellent. I'm actually in the process of working on details for our next AML caregiver meeting. So the date and topic are still to be determined, but you can check our website at the link here on the slides for all of our upcoming events, and you'll receive an email when our next AML caregiver chapter meeting has been set. I'd also like to encourage you all to complete our post-event survey that will be sent out to you via email. There's a section for you to provide your thoughts on what types of topics you would like to learn about in the future. Your feedback really means a lot to me, and having your input will help me to set events up that are most beneficial for you. So I look forward to reading your responses. Once again, thank you to our HealthTree community for AML event sponsors, Bristol Myers Squibb, Amgen, Genentech, AbbVie, and Jazz Pharmaceuticals. And thank you for helping us to build a strong HealthTree community for AML. I appreciate you all. Hope you have a great rest of your day, and really hope to see each of you again soon.
Thank you.
Bye.
Thank you.